No problem, and thanks for guiding me through the location you were in. And this actually shows that chairing a session can look simple, but it can be a dangerous task, and you manage this very, very well. Thanks for this. What I was saying right at the beginning is that my topic, the title of my topic was early COPD, mild COPD, pre-COPD. I changed it a little bit, as you saw. I added COPD in young people. We're going to talk about this. And the question I will try to answer is, what are we talking about? And this is not a trivial question. Here are my disclosures. And let's go first to a bit of concepts and definitions, because basically that's what it is all about. And I will begin with the very well-known definition of COPD, which you can see here. And I just wanted to highlight two components of these definitions, which are there. The first one is the symptoms, and the second one is airflow limitation. And what has changed a little bit a few years ago is that these two parts of the definitions are both necessary to talk about COPD in a given patient. Airflow limitation alone is not enough. The idea behind this was that when you see a patient with airflow limitation but with no symptoms, this patient does not need any treatment if there are no symptoms, and so this patient shouldn't be labeled as having a disease. Second thing I want to address is the idea we have about the progression of COPD, what I called from health to death, which is basically the natural history of the disease. And what is pictured there is the traditional view of this natural history, beginning with the induction of the disease by the interaction between some genetic predispositions and exposures, leading to, after some latency period, to the onset of the disease, and then to the progression. And what you can see here is that this progression is viewed as linear. And during a long period of time, this is how people were thinking about COPD. And what we know now is that, to summarize, this is wrong. The progression can be linear, of course, in some subjects, but it's much more complex than just this straight line. So this has led to the Gold report to propose some definitions to try avoiding confusion. Confusion, when you were reading papers on this, you saw mentions of early COPD, of pre-COPD, and well, people were not really knowing what this was meaning or what they were trying to say using this terminology. So Gold proposed very simple and clear, I think, definition. The first is early COPD. What do we mean with this term? This is biologically early COPD, which means we are near the beginning of the process. The process has begun. The patient has COPD, as defined, as I mentioned, by symptoms and airflow limitation, but it's really the beginning of the disease in this patient. Okay. Mild COPD, we all know what it's all about. It's mild airflow limitation, FEV1 more than 80%, but there is COPD, so there is airflow limitation as defined by the low FEV1 on FVC ratio. Okay. COPD in young people, it's simple to understand. It's COPD in patients aged between 20 and 50 years of age, which is relatively young for people with COPD. And the last, but not least, term of this list is pre-COPD, which is probably the main topic I will address during this talk. And pre-COPD is defined in the Gold document as respiratory symptoms with or without detectable structural and or functional abnormalities in the absence of airflow limitation. In the absence of airflow limitation means with an FEV1 and FVC ratio more than 50%. Okay. I don't fully like this definition. What I would prefer is respiratory symptoms and or detectable structural and or functional abnormalities in the absence of airflow limitation. These two definitions have one thing in common, which is the absence of airflow limitation, because there is no COPD, so there is no airflow limitation. But I don't think it's only about symptoms. It can also be structural abnormalities which can be detected on CT scan, for example, even in patients who don't have any symptoms but have some emphysema or some air bubble thickness. And it can also be functional abnormalities such as low DLCO or increased lung volumes in the absence of airflow limitation, and sometimes these patients don't have symptoms. So there are three ways of entering these pre-COPD definitions: symptoms, function, and imaging. Now let's go back to the origins of COPD, because this has to do with the concepts underlying these definitions. We have two ways of getting COPD. One is the accelerated decline in lung function, which is the classical way of getting COPD. You have a normal lung development. You go up to the 100% of your lung capacity, and then your lung capacity decreases fast. Okay, that's what happens in smokers, for example, which are susceptible to the deleterious effects of cigarette smoke on the bronchi. The second way of acquiring COPD is an impairment in the development of the lung. And this is what you see with the curves which are at the bottom of the picture. And you see these patients have a lung development, an increase in lung capacity, which does not go up to 100%, stops somewhere in between. And after that, some will have an accelerated decline, but some will have COPD without declining too fast. It will just relate to the abnormality of the development in their lung function. You have considered these differences in the trajectory of lung function and these differences in the acquisition of COPD. You can put on this graph what are the concepts behind early COPD, COPD in young people, mild COPD. Early COPD, here it is. You see, this is shortly after the beginning of the disease. So early COPD means that biologically, the phenomenon leading to COPD has just begun, but the disease is already there. So we have a real COPD, but has been initiated relatively not far away, temporally speaking. Now, if we go to COPD in young people, well, that's extremely simple. You just consider the age range. It's COPD before 50. You can label this COPD in young people. Okay. Now you have mild COPD. Again, that's easy. It's another question of threshold, which is 80% predicted. So these are people with mild COPD. But then you have the concept of pre-COPD, which is a bit more complex. As I defined it before, that's my definition. Well, I'm not the only one to think like this, hopefully. This is the definition by respiratory symptoms or lower lung function or imaging abnormalities or combinations of these, and an FEV1 FVC ratio, which is still within the normal range. Okay, so I think we have clear definitions of these terms now. What can be interesting is that the relative contribution to the risk factors of COPD, which you can see here, can differ based on the trajectory of the patient, which has led the patient to acquire COPD, to develop COPD. And you see here, I won't go into the details, in the green square you have the factors associated with accelerated decline, and in the red square, you have the factors associated with altered lung development, and these are frequently called the early life origins of COPD. And you have at the bottom of the screen the factors that are involved both in the accelerated decline and in the early life origins, and these will contribute to the development in COPD in a complex manner. What's interesting too is that in addition to the different trajectories of lung function, altered development or accelerated decline or combinations of both, you have also different structural profiles of evolution. In this study, which was extracted from the COPD gene cohort, and it was validated with the ECLIPSE cohort, what the authors found using artificial intelligence to analyze CT scan, longitudinally performed CT scans, they found two types of evolution, structurally speaking. One was the evolution of tissue damage, which is emphysema, to airways damage, which is increased thickness of the airways and loss of airways. So that's what you can see on the left part of the graph. And on the right part of the graph, what you can see is the other type of development of the disease, which is from an airway damage and structural changes, which means increased wall thickness, to emphysema. So what they saw is that depending on the patient, some will begin with emphysema and go to acquire some airways structural changes, and some will go completely the other way around, going from the airways changes to the tissue damage and emphysema. And again, one of the questions is, when you think about pre-COPD or early COPD, it will be completely different from one situation to the other. One will be an emphysematous change, the other will be an airways change. And both will lead to COPD, but with very different structural trajectories, not only lung function, but also structural trajectories. So this is just to illustrate that these issues are quite complex, because when you speak again about pre-COPD or early COPD, depending on the trajectory of the patient, both the lung function or the structural trajectory, you will be referring to very different situations, although they will be covered by the same terms. What is the respective contribution of the two types of trajectories leading to COPD? This was studied in several studies, actually. The example here is the Copenhagen City Heart study. So what you have is a group of patients that were recruited in the 70s and 80s, and they were thereafter diagnosed with COPD 20 to 30 years later, during the prospective follow-up. And what is interesting is this provides answers to the questions: how do these patients develop COPD? Is it accelerated decline, or is it impaired growth? And it was half-half, which is very surprising, actually. Some of these patients followed an accelerated decline trajectory, about half of the patients developing COPD. And you see the rate of decline was 60 mils per year, so really accelerated. And the others had more an altered development with rather normal, maybe a little bit accelerated decline over the years. And so this was something really surprising. The next question, when you look at these different trajectories, which have different implications when you think about early disease or pre-COPD, when you now look at the mortality and the prognosis, you see it's very different. In the patients who have an accelerated decline, who are in red, you have an accelerated mortality too. Inversely, in the patients who get COPD through an abnormal development, they have no difference in mortality as compared to the no COPD population. At least that's true for the respiratory disease mortality. For the all-cause mortality, these patients with abnormal lung development are in between a kind of an intermediate situation. So it means that these two trajectories have very different implications in terms of prognosis. So the messages here are simple. You have two origins and two types of trajectories leading to COPD, and they are both frequent. The fast decliners die earlier, and this means that the prognostic value of the decline is superior to the prognostic value of FEV1 as an absolute value per se. And the question is, are these different phenotypes or are these different conditions? Should we label them the same? And that's true for both COPD itself, but also the early phases of the disease, early COPD, and the preliminary phases, which are pre-COPD. Now, what is pre-COPD? I will go rather fast because it's quite straightforward, from at least instinctively, and there are a lot of data all concerning the same. Here you have smokers without COPD in spiromics. These are in the middle of the graph. These are in the middle of the graph, and what you can see here is that you have smokers and ex-smokers with preserved lung function who have symptoms, CAT 10 plus, and it's half of the patients with preserved lung function have symptoms. So they don't have COPD, but they have symptoms. This might belong to pre-COPD. Now, if you look at spiromics, you see exactly the same. You have, I will highlight it here, you have smokers with mild to moderate COPD and a few symptoms. They have few exacerbations. But if you look just on the left of this red square, you have patients with preserved lung function, but they have symptoms. CAT score is more than 10. So they don't have COPD, but they have symptoms. And when you look at their level of exacerbations, which is the y-axis, it's higher than patients with COPD and no symptoms. This means that having symptoms, when you don't have COPD yet, but you have risk factors, having symptoms is pejorative in terms of prognosis. And that's why pre-COPD has been individualized. If you look at the same category of patients, this time in spiromics, another cohort, these were symptomatic smokers. They don't have airflow obstruction, but they have increased airway wall thickness. So that's why I was including imaging features, structural changes without airflow obstruction in the pre-COPD definition. Not only symptoms, because these did not all have symptoms. Even if they don't have symptoms, if they have increased wall thickness, they will have more risk of exacerbations, for example. We're going back to this. In the COPD gene study, again, same type of finding, emphysema or gas trapping can be present in smokers or ex-smokers in the absence of COPD. So this might be, if we believe in it, the component of the pre-COPD status. Wow, that's a busy slide. So just look at the right part, the text. What it tells you is that in the COPD gene studies, 43% of the smokers that were included in the cohort and had a normal FEV1 FVC ratio, so no COPD, had air trapping or bronchial wall thickening or emphysema on CT scan. So they had the imaging pre-COPD. And among these, it was not only imaging, because some of these had MMRC2+, which means significant exercise-induced dyspnea, which was much more than the never-smokers, of course, and which was about the same as the patients with GOLD 1 COPD. So you have patients who don't have airflow obstruction, so they don't have COPD, but they have imaging abnormalities and clinical features that look like what you have in COPD. Are they pre-COPD? I would advocate that yes. Another cohort, Canadian one, CanCold, showing again, I won't go into the detail, I will go fast through this slide, showing again that there are some CT scan abnormalities before airflow limitation, and this is both for expiratory trapping, bronchial wall thickening, or emphysema. And these patients with imaging features of COPD but without COPD, they have more exacerbations, they have more symptoms also. That's the left part of the graph. They have more wheezing, breathlessness, chronic cough, chronic phlegm, and they have an increased risk of exacerbation. So this suggests that having these imaging abnormalities or having symptoms is not trivial, even in the absence of airflow limitation, and the exacerbations they have are not trivial either, because they have a significant impact on the life and on the work of the patient. So how can we summarize the significance of these pre-COPD status? Here you have it again. These patients without airflow limitation but with symptoms will have increased exacerbations rate. So this is first prognostic influence. They will die quicker. If you look on the right of the graph, you have the explanation of the various curves, and you see that the gold 0 patients, which was the ancient label for pre-COPD, in a way, patients with chronic bronchitis but not airflow obstruction, they die more than those who don't have airflow obstruction and don't have symptoms. So having symptoms is something. And if you look at this is a paper that was coordinated by Nicola, and she did really a wonderful job, because she collated all the data that we have from all the cohorts you can see on the left part of the graph, and she looked at the relationship between the symptoms of interest, and we'll see the lung function and the imaging features of interest in the next slide, and prognosis. And what you can see here is that when you have chronic cough and phlegm without airflow limitation, you have an increased rate of decline in FEV1, you have an increase, and it's a marked increase in the incidence of COPD. The rate ratio for incident COPD and the odds ratio, whatever the way you calculate this, are increased. So that means that symptoms without COPD leads to COPD in some patients, not all, but in some patients. It increases the risk of having COPD above the level that is just due to the risk factors, smoking, for example. And this is also true for lung function. When you look at lower FEV1 without airflow limitation as defined by FEV1 FVC, when you look at lower FEV1 or lower DLCO, you have an increased risk of incident COPD in the next years to come. Same for emphysema or airway wall thickness. That's what you can see here. Still the paper by Mile and you see that these features, airway wall thickness or emphysema, are associated with an increased risk of acquiring, in a way, COPD in the following years during follow-up. So what we have now, we have symptoms, we have imaging, we have lung function abnormalities without airways obstruction, which all have some consequences. They are all associated with an increased risk of getting COPD during follow-up, but we don't really know if they all have the same significance or relevance. We don't know if they are really a step in the way to classical COPD, or if they represent some kind of different condition when compared to, let's say, full COPD. What we can also imagine is that these are not associated with traditionally measured COPD, which means not with a low FEV1 or an FVC ratio, but they could well be associated with other markers of airflow limitation. And maybe it's finally just a question of insufficient sensitivity of classical spirometry to detect airflow limitation. And we could imagine that using oscillometry, lung volumes, diffusion, it could show much more sensitively the appearance of airflow limitation. So I will go very quick, but we all know that if you use a fixed threshold of FEV1 and FVC ratio, you will underdiagnose COPD in some patients and overdiagnose it in others. So FEV1 on FVC fixed ratio is certainly not the best way, physiologically speaking, to diagnose airflow limitation, but it's the easiest. And if you go into even more details, here are the results from oscillometry, and you see it's not very easy to read. These are measures of all the oscillometry parameters. And the message here is that if you look at this, the red square, what you have is patients that have symptoms but not COPD as defined by the FEV1 on FVC ratio. And these have abnormalities in oscillometry, which means that they have some airflow limitation of the small airways, which is not detected by spirometry, but is detected by oscillometry. Oscillometry is not a routine test for now, but it could lead to changes in the way we define airflow limitation and COPD in the future. So all this could be it could be just a question of measurement issues. So to conclude, we know that symptoms and airflow obstruction, airflow limitation, both contribute to the definition of COPD. We know that there are patients who have symptoms or imaging or lung function abnormalities, but they don't have COPD because they don't have obstruction. And we know that they are, as I just showed you, they are at increased risk of transition to COPD. And for this, they can take both trajectories of accelerated decline or abnormal development. So these do exist. We can label these as pre-COPD. And probably there are several subtypes of pre-COPD. And there are also some patients, I didn't touch on this because of time, who have chronic airflow limitation but don't have symptoms. So they don't really have COPD because they don't have symptoms. Again, this can be a question of measurement of dyspnea, but we also know that these patients with airflow limitation but without symptoms have a better prognosis than the patients with the same level of airflow limitation but symptoms. So maybe it's a question of adaptation, and maybe it's not exactly the same conditions. But anyway, this is the summary that was proposed by Meila and Han in the Blue Journal paper on pre-COPD last year. And I like this picture very much because it's a very nice summary of what we want to transmit as a message. These are the patients with pre-COPD based on symptoms or function, but a normal FEV1 on FVC ratio. And this proportion of this, which we don't exactly know for now, will go to develop COPD. And the big question then is, can we prevent this? Can we identify these patients with pre-COPD and propose them an intervention that will stop the development of COPD? That's the big challenge we have now. So my last conclusions will be, should we change the definition of COPD? I would answer that this is a question of definition, and it's probably not the biggest problem we have. What we could do is increase the sensitivity of what we use to measure airflow limitation. Maybe we should include pre-COPD in COPD, but I wouldn't like it because by definition, pre-COPD is before COPD. What we certainly need is to expand our knowledge of this pre-COPD situation. And for that, we know more observational cohort studies, and we will need intervention studies to try to see if we can prevent the development of the real disease beyond pre-COPD. Having said that, thank you for your attention.